We're going to try to make sure that we keep our comments brief, but very focused and frameworking and putting a framework to what we think is a very important topic in the context of ECHO in its various facets of the need for ECHO in the context of an urban environment, rural environment, internationally, et cetera. So in doing that, we decided to be not very formal about this, but very informal about this, which goes with my Chicago ways, and that's okay. We'll get through this. So we'll just do our own introductions. And so I am Robert Wynn. I'm the director of the Cancer Center at the University of Illinois, and I'm also the Associate Vice Chancellor of Health Affairs for Community-Based Practice. And probably you're wondering how both of those come together. Someone's the director of the Cancer Center, but yet they're in the community. Hopefully I'll explain why, how that came about. Trying to go to the slide. I think that one of the biggest problems that I can actually tell you that we all recognize and that we're hitting at it today is this issue around alignment. And that the fact of the matter is frequently what we talk about aligning processes, we really aren't even actually in the game yet. And what I mean by that is that my own experience in Chicago is we have multiple academic universities, we have multiple community hospitals, we have federally qualified health centers that are heavily populated throughout Chicago and Illinois, and yet we're not connected at all. And this lack of connection actually leads to some very interesting data that I'll show you that has a very negative outcome. I'm reminded that as we talk about our big technologies and as we talk about all of the big miracle drugs and all the wonderful things that we're doing, that there are very real people, as you all know, so this is speaking to the choir, who aren't getting any of this, who aren't benefiting at all. And yet we scratch our head and we wonder, well, you know, what's the reason? Well, the reason is, I think in part, this system around trying to literally not talk about ownership but alignment and making it make sense. Now, having said that, at least in my neighborhood, where I grew up in New York, also in Detroit, where I did a little bit of training, and now in Chicago, the reality is everywhere I've been, even in Colorado, the way you win the game is to get to the caregiver. So the reality is, if you can get to us, you do fairly well. If you can get to us, we may even do something about the sarcoid that you may have, or the cancer that you may have. In this case, I think, like Copernicus, that we should blow up this model in the context that the concept that the only way to win is to get to us makes no sense if what we went to medical school for, we went to nursing school, was to say, very first of all, that it wasn't an occupation, this was an avocation of service. By that definition, it means that we should be going out to serve. Now, this is just a quick example. I don't have a lot of time to talk about this, but I run an operation of 13 federally qualified health centers that happens to be the third longest running federally qualified health center in the country. After the one founded by Jack Rieger in Dorchester, Massachusetts, and John Hatch obviously helped them with Jack, set the second one up in Mississippi. This is the third longest running federally qualified health center in the country. It serves the south and west side of town. Now, the interesting thing is, prior to my coming, the university had these things, and one of the unique factors, and why am I talking about this, is because while most universities partner up with federally qualified health centers, we're one of less than 5 in the country, I believe, maybe even 4 universities that kind of owns and operates its own federally qualified health centers, which is a unique model with unique opportunities. Now, having said that, I started recognizing that with these federally qualified health centers that were created in the 60s, right, to be the undergirding, right, of healthcare in the United States, which is interesting because when most people think about federally qualified health centers, they only think about poor, and they don't think about the word community doesn't even come up. But the interesting part of our federally qualified health centers, we scratch our heads, they're right in the communities, and while we point to Canada and while we point to everywhere, we should be pointing to what was placed in here 50 some odd years ago and being able to figure out how to resource those places up, because those places are actually in the communities we say we want to serve. So it just so happened that, you know, being a basic scientist doesn't hurt. I'm telling you, if loving science is wrong, I don't want to be right. That is true. But the question is, how do we get the science to the people? Now, it turned out that in this model, I just picked out 6 of them, and these happen to be areas that are in the south and west sides of town of Chicago. When I looked at these 6 FQHCs that were embedded in some of the hardest communities and the most underserved communities in Chicago, I started recognizing that there was a pattern. And the pattern is that there were zip codes, and in Chicago, we call these zip codes, a number of zip codes can make up a ward, an actual designated area that an alderman was responsible for. So I started figuring out who, in which wards, in which groups of populations of people from different wards were coming in to visit our clinics. And to keep it short, it turns out that by doing that, what I recognize that while we're really do-gooders and we mean well, it turns out that when you look at engagement, we engage other health people, but we don't really engage our civic leaders, and sometimes we don't even engage we engage the mayor, maybe the governor, but we rarely engage these city council people or these aldermen, who really are the heart, in this case, of a ward. So this is an example of Willie Cochran. Alderman Cochran is a wonderful guy. And in fact, when we met him, the very first time, his words were, "So what the hell does this mean to me? For the last 10 years, you guys give me data, you give me more data. I don't even know what it says." So I said, all right, I think this is the first time I can maybe give you something to take a look at. So not only were we able to talk to Willie about his uninsured rate, give him his physical ward map, which we, by the way, Google is not always right when it comes to these things. You actually do have to drive out and check yourself, just saying. And we were able to give him the regular demographics. But what we were really able to do is to do the following. Now, when I showed Willie this slide, Willie essentially said, wait a minute, Dr. Nguyen, does that mean is red bad? And I essentially told him, yeah, red is bad. And then he says, well, when you bold out the numbers, does that mean it's even worse? And I said, yeah, okay? What I'm trying to demonstrate here, and there's a lot of red there, but if you, for example, would look at the prostate line, and you would look at, I think it's West Inglewood and Greater Grand Crossings, but if you look at those, that's the mortality, right? We've looked at incidence, prevalence, and mortality, but when we were able to just sit down at a table with Alderman Cochran and says, you have 3 times more people dying in your ward from prostate cancers than even African Americans tend to die in the United States. That got his attention. Now, as a result of getting his attention, it also meant that we actually had better conversations with our community hospitals, because what we found out is that some of our community hospitals, while well-intentioned, were under-resourced. And it's no wonder why we would have some of our patients who would come in from the hospitals and say, well, you know, I don't see doctors because what are you guys going to do to me anyways, when you have a knowingly under-resourced community hospital, which is the only one that's actually closest to them. Now, I actually think it's unfair to start pointing fingers at what our patients aren't doing when some of these folks have to take 3 buses and a train in some of the most violent areas of Chicago to get to us. Second, what's even more crazy is that we want them to come through our 9 to 5 hours. Some of these folks are getting up at 3:30 in the morning to catch a bus, to get to Rockford, get on the train, to actually have their job, and in fact, they're coming back late. It turns out that while Walmart is big, I'm not picking on Walmart, because there's many other Walmarts out there, but the hours aren't always conducive to getting care. So the issue is not, well, we should think about, the issue is what are we going to do? The reality for me, big data mostly just begets big data. That begets more big data. The issue for a guy like Willie Cochran and others in Chicago is, how do you take this big data and get it down to a digestible form that you can then have an actionable item? And once you have that, how do we determine the resources? Now, I'm not going to spend any more time other than to show you kind of this last slide, and this is one of our heat maps. But by doing this sort of approach, we now know where the hot spots are in Chicago. And you'd say, well, that's the end. That's not the end. That's only the beginning, because it fits in with the food deserts and then the education type issues and the economic issues. And so it's not just a one thing does it all. It really now allowed me and our team to engage really not only on the health issues, but around the economic needs, around the educational needs that our university can now bring to him. And that's the new kind of conversation that's actually going on. And so when I ran into Sanjeev, and it was like, I would say, he was just awesome. He had me before hello. When he walked in the door, I was like, all right, man, I know about you. This is great. So this concept of what ECHO can do potentially in an urban area is an important discussion, and one that I know you all know, but one that I wanted to just frame the importance of ECHO, not only in the context of what we've traditionally known, but how ECHO could potentially actually serve a great need in the cancer world. And with that,
thank you, Rob. That was great. I'm Ellen Baker from MD Anderson Cancer Center, and is the microphone on? Can you hear me? We have some hotspots, too, that we've identified in Texas, and I thought I'd just mention what we're doing in the world of cancer using the ECHO model, and then talk a little bit about some of the challenges that we face in using the ECHO model and in trying to prevent, to screen, and to treat and palliate cancer. So our first project, ECHO, started about 2 years ago at cervical cancer prevention, and our hotspot in Texas is the Texas-Mexico border, where the incidence of cancer is, cervical cancer is about 30% higher than the rest of the state. Morbidity and mortality from cervical cancer. It's a very poor community, largely Hispanic, underinsured, uninsured, and very transient. There are fewer providers in the public system here as compared to the rest of the state, and there's actually no gynecologic oncologists in the public system in this area of Texas. So our partners are an FQHC called Suclinica with 3 locations, a mobile clinic, and a clinic that's run by the University of Texas Medical Branch at Galveston. And over the last 2 years, we've had other people join. We're a very welcoming group, and so we've had providers from the Houston area, the public hospital in Houston, join us as well as some gynecologic oncologists and gynecologists in the Houston area who are retired but do volunteer work around the world. And it is run by our faculty at MD Anderson, a gynecologic oncologist and gynecologist, and another faculty member from University of Texas in Galveston. At one time, we invited some colleagues from the Cancer Diseases Hospital in Lusaka, Zambia, to join us, and they came to 1 or 2 meetings and said, gee, this is, this is great, but we don't need help with management of cervical dysplasia. We need to know how to manage invasive cervical cancer, because that's what we see. And Zambia has one of the highest incidence of cervical cancer in the world. And if you get cervical cancer in Zambia, there's a pretty good chance that you're going to die from it. So we did a break-off Project ECHO with the Cancer Diseases Hospital in Zambia, and that's been operating for about 1.5 years. And we focus on cervical cancer and on management of breast cancer. Very much like a tumor board, we have a multidisciplinary team at MD Anderson that meets with the multidisciplinary team in Lusaka, and over the years we've become very good friends, and we have learned a lot about each other. Moving along in Africa, it's a long story, but we also are doing a very similar clinic in Mozambique. So for about the last 8 months, we've also had a management of cervical and breast cancer ECHO clinic with doctors from the Central Hospital in Maputo, Mozambique. I'll just say that it had a lot to do with the First Lady of Mozambique, who is a very big advocate for women's health and was very encouraging in getting MD Anderson involved, as well as others, to provide assistance to the doctors and the staff in Mozambique. Along the way, we met some of our colleagues from Uruguay, and they participated in some of our clinics as well, but we've done another breakaway clinic, and you'll hear Fernanda talk about our cervical cancer prevention and management in Latin America, a partnership of about, I think there's 10 countries that participate in that ECHO project. We also run a tobacco treatment ECHO for patients with mental illness, and we partner with state-run mental health clinics around Texas, providing support to the mental health providers to also provide tobacco treatment. Of course, patients with mental illness tend to smoke more than the general population. They smoke more cigarettes, and on average, they die 25 years earlier than others, and 50% of deaths are related to tobacco use. And so this is a very vulnerable population, and one that's been largely ignored and this challenge of providing these services has really not been available. We have 2 other projects funded in development: survivorship, in which we'll partner with family medicine residency programs in Texas, and then palliative care, where we plan to partner with palliative care experts in a few centers in Africa. But almost all of our ECHO programs are part of larger strategies to enhance training, enhance patient outcomes, and to reduce disparities. And through ECHO, we develop strong relationships, a better understanding of local challenges and context, and it serves as a foundation for the development of other collaborative projects and activities. But ECHO alone is frequently not the only way that we can address these issues. For example, in the South Texas cervical cancer prevention ECHO, we are talking about management of cervical dysplasia, and that in the United States involves colposcopy, but if you don't have enough colposcopes, it's really hard to do colposcopy. So through grant funding, we have purchased colposcopes for some of the partners, and Chris will talk about that. And we've sent 5 providers to the ASCCP National Colposcopy course, so we've doubled the number of trained colposcopists in South Texas in this particular region. We also have medical assistants and nurses who are working on ensuring that patients don't miss their appointments. They come in per schedule for their screening, and they get properly navigated for further care and follow-up. In global work in low-resource countries, any meaningful discussion has to consider the context, the culture, and the resource limitations. And we tend to refer to Africa as if it's one country, but of course it's not. And while there's a lot of similarities among the different countries, there are a lot of differences as well, and the challenges can be quite different. The U.S. standard of care practice is not possible or feasible in most places in sub-Saharan Africa. And so the solutions often require creative thinking, far outside the normal box that we are comfortable with. So we've been meeting with doctors from Maputo Central Hospital for about 8 months, and we know each other fairly well. We meet about once a month, but occasionally we meet more often, particularly in advance of a visit, so that we're very prepared to hit the ground running. You talked about the limitation of resources in Chicago, and there's many places in the U.S. with severely limited resources, but Mozambique is a country of 24 million. And I'll just say at MD Anderson, we have 13 breast pathologists. In Mozambique, there are 9 pathologists, and that's in the whole country. There are 6 oncologists, and there's no gynecologic oncologist. So cervical cancer is the prime cause of cancer death among women in Mozambique. Many, many challenges, many resource limitations, but a lot of energy and a lot of will and a lot of partnering to try and do better. The language is Portuguese, and without the partnership that we have with our colleagues in Brazil, who are very enthusiastic and very committed, the Project ECHO with Mozambique would not be successful. We have spent time traveling back and forth. We were in Mozambique in January for a week with our medical team, and the Mozambique physicians will be in Brazil this month for, I think, about 2 weeks. So it's an ongoing process, and ECHO is sort of the foundation and the genesis and what we use to develop all these other activities. In Zambia, after a year and a half of ECHO clinics and several visits back and forth, there's a funded joint research project aimed at improving the pathology quality and processes in the lab at the University Teaching Hospital. Many challenges remain, and probably the most essential element of some of these clinics is patience, because progress is slow and the challenges are many, and every time we turn around there seems to be another one. I was asked to mention a little bit about some of these challenges. Internet reliability is a huge problem for any tele-ECHO clinics, but it seems to be improving. We struggle a little with meaningful metrics. It's especially difficult when record keeping is poor or non-existent, as it is in some of the places that we work. But ECHO is largely the glue that holds many of these efforts together and the foundation that we are using to continue to build partnerships and to make some progress. Thank you.
So that was great. Thank you. Chris, so you're boots on the ground. So would you introduce yourself and tell, your experiences, really boots on the ground with this?
Well, I'm a nurse practitioner, and I work at one of the FQHCs in South Texas, along the border, Texas-Mexico border. And as Ellen mentioned, we know that we have a higher incidence of cervical cancer and cervical cancer mortality. Someone was asked, why did I want to participate in this? Well, what a wonderful opportunity to partner with MD Anderson, the experts, and to be able to learn and to share everything that we, all the knowledge that can be gained, so we can provide the best care to our patients in South Texas. Some of the other benefits that we've seen, education. This has been just a wonderful experience. We have tele-clinics, or I like to call them tele-mentoring clinics, where we listen to a presentation, and then there's also case presentations that we submit as participants. And that's helped us really learn a lot. What's really great is that all these sessions are recorded, so we can view them on the website if we happen to miss one, or if we want to go back and review. What did they say about that? So that's been awesome. The other thing, too, is, of course, there's CME offerings that go along with it. Well, what about professional growth? As Ellen mentioned, we've gained new colposcopists at our clinic, and that's been wonderful to add more of us to be able to perform colposcopy. Of course, those of us that have experienced, we were lucky to go to the ASCCP conference and gain more knowledge there, along with these rapidly changing algorithms for taking care of pap smears. We've been able to do more staff education in our clinics, which has been great, keeping the interest up as what are we doing, and they help also with interpreting for me in some cases, which has been just wonderful. We've been able to also have one of our gynecologic physicians trained to perform LEAP, and I'll discuss that in a little bit more detail later. Well, another benefit has been the networking that we've had with all of our partners, and it's been a wonderful experience to listen to what they're doing and the challenges that they face and how they've overcome them. Of course, our consultation, this has been one of the best things. I've been able to consult with the experts at MD Anderson, and also with a physician from the UTMB, University of Texas medical branch, that comes down to the Valley about once a month, I understand. So one of the challenges has been these rapidly changing PAP guidelines, and those of you that are maybe in the field know that yes, there's an app for that, but they're very complex. They're very different from the way we used to manage PAPs and also manage the abnormal pathology. And so not everything fits into these little algorithms. So what's also wonderful, I don't have to wait for that meeting to come to present a case. I can either get on the phone, email, and I get a response back from the physicians, and that's giving me guidance on what to do with the patient. So that's been invaluable. New equipment. You mentioned new equipment. Yes, we received one of the new colposcopes, and we received a LEAP machine. We now had the physician that was trained to perform LEAP, but we didn't have the equipment. Before we had the equipment and she was trained, in South Texas, I believe the population is 1.5 million people. We have one public clinic that deals with dysplasia, abnormal PAPs, and the treatment. And the physician comes, as I mentioned, coming down once a month to perform LEAPs. So that means that our appointments are delayed, and with a delayed appointment, we know that the patients sometimes don't come. And since we're along the Texas-Mexico border, many times they go to Mexico to receive care, and we don't know to whom they're seeing and what's going to be happening to them. And of course, they always have the private option, but that's cost prohibitive to our patients. So, colposcope. I'm going to tell you a little story. Again, this colposcope was placed in our Willacy County Clinic, which is a county that's very poor, that most of the population live below the federal poverty line. And one afternoon, in fact, it was a Friday afternoon, and my last patient of the day, I saw a 51-year-old gravida-4 para 3 female who'd been approached by a community outreach worker, and she'd not received any kind of medical care for 23 years. Well, she had multiple medical problems, but when I did the pelvic exam, it was obvious that she had cancer. So with that colposcope, and thanks to ECHO, I was able to perform that colposcopy right then and there that afternoon, get those biopsies sent off, order the additional scans and tests that needed to be done, and she was seen by one of our gynecologists the next week. Now, to fast forward with that, she is in the hands of a gynecologic oncologist, and she's doing well.
That's awesome. Fernanda, you're going to tell us a little bit? Now, we had threatened that we were going to do this whole thing in Spanish, but I guess we're not. We're going to do it with an interpreter too, so that's okay.
Thank you. I'm Fernanda Nosar from Uruguay. I'm a gynecology. I work in the Women's Hospital and in the School of Medicine. Y ahora voy a hablarles, les pido disculpas porque voy a presentar en español, pero creo que va a ser menos confuso si hablo en español con un traductor y aspiro a que Bernie pueda hasta mejorar mi presentación.
And I apologize about the whole speech I'm going to give. It's going to be completely in Spanish, but I hope that using the interpreter Bernie, that this will improve upon my presentation.
He is my brain.
We're actually right now coordinating two clinics associated with ECHO, one at a national level and one at an international level. The first one, which we started at a national level, I wanted to share the analysis on how we got that started to get that going through Uruguay. And taking this into account with our collaborator, Dr. Cohen, we wanted to see if the 4 different areas that form part of our clinic were qualified to meet the components of ECHO. So this way, with the professionals that we were working with, we wanted to know if they knew the different tools to work with, and we wanted them to feel stimulated or to feel encouraged to use those tools for this knowledge and program. And the other thing we needed, which was absolutely necessary, was to use an assistant model and use the institutional model to coordinate both. And in the relief for patients, we wanted to bring this forward because one of the things that was affecting them was the cervical cancer. And finally, we looked at this in the School of Medicine to see if this information was useful in the training of future providers. And since we launched this about a year ago in Uruguay, we also started looking at the impact that each one of these components has had. And as far as the professional level, we're looking at each one of the professionals that have taken on looking into cervical cancer. And we have to remember that this takes a fourfold way to look at this disease, from the primary care to four stages later, and all of us can come on board with this at the same time. At an institutional level, this model of ECHO has come to stay, and it now forms part of our assistance model. So what is it that this brings value to the patient? Well, we now have better care for them because we have the ability to improve the care for any patient involved. It's also important to note that with every ECHO clinic that we have towards the end, we also bring forward some of the case studies of the patients. And finally, when we're talking about education, pure education, this program of ECHO has allowed us to coordinate education with other participants and peers through ECHO, and has now formed part of our permanent continuing education program. This is what we have seen at the national level. And when we're going to analyze taking this beyond a national level to other countries, we need to analyze the strengths and the different challenges that each nation presents. So in a professional level, what we've done is we've coordinated with other professionals that already have some experience following these kinds of models, and now we just strengthen those relationships so that we can coordinate with them. And at the institutional level, we have met with people that are in charge of taking with the care of each one of these different things so that we can strengthen and coordinate with them. And as far as the patients are involved, we also connect with each other to learn about the different realities for each person as far as the cultural, economic, and social realities that each one of these patients brings and we have to treat. And as far as continuous medical education, well, this also creates a point of reference with the different institutions that teach medical providers. And to end, I'd like to tell you about what our current challenges are. Now we have the challenge of measuring these results, both at a national and international level, so that we can show these. At a national level, we plan to show these at a local assistance level, so that with the clinical cases that we present, so that we can show these results. Besides also measuring the satisfaction of the professionals that are involved in the care. And at the international level, it's a big challenge for us to measure the impact of ECHO in the different countries, since it is also very difficult to demonstrate or to show if we are able to make an impact at an individual level.
Para finalizar, quiero decirles que yo comprendo el inglés y creo que Bernie tradujo perfectamente lo que dije.
And to finish, I would like to say that I understand English completely well, and I think Bernie did a fine interpretation.
That's awesome. That's awesome. So I know that we want to get questions in for sure. And so what I'm going to ask Patricia, and again, this is my old time I spent in Colorado, is to do a John Elway-like 5-minute approach to telling everything we need to do as a threads that you're hearing in the context of social justice as well as health equity, and how ECHO sort of interfaces with that, because I think you hear a little bit about that coming in. So I got you on clock.
Okay.
Okay.
Thank you, Robert. And it's such a privilege to be with such leaders in health equity around cancer. I'm Patty Doigas. I'm a director at the Bristol Myers Squibb Foundation, and it's really our mission and ECHO's mission that brings me here today. We're both very focused on promoting health equity and improving outcomes of heavily affected populations around the world. We have a number of programs in sub-Saharan Africa. We're building on our HIV/AIDS initiatives with a cervical cancer initiative in Central and Eastern Europe. We focus on cancer nursing, trying to expand the role that cancer nurses play, not only in the clinic, but also in public health. And then in the United States, we have 2 new programs. One is focused on lung cancer in the Tobacco Belt, a very affected area, and the other is a national initiative looking at not only cancer care, but other kinds of specialty care for underserved populations. And there we're looking at lung cancer and skin cancer and a number of others as well. And we are really brought here by this mission of equity, which starts always with Sanjeev in terms of his commitment to human rights and social justice. And it doesn't strike him as particularly fair that somebody, just because they live in a rural area or in a low-resource area, doesn't get access to the kind of care and support and treatment that they need. We would all want that for ourselves, so we have to want that for everyone else. So the cancer community, however, has been somewhat slow in coming to health equity work, and it's not, in terms of the NCI Comprehensive Cancer Centers, entirely their fault. In a way, they haven't actually been asked to lead it and to play a very important role. When you look at the criteria for national comprehensive cancer centers from NCI, it really focuses on advancing research and then utilizing these best technologies to produce excellent outcomes for patients, but then not necessarily to take it beyond that, to build the train tracks, if you will, of cancer care so that innovations of any kind, whether it's in public health, whether it's in awareness, whether it's a new screening approach, whether it's a treatment, whether it's palliative care, whether it's psycho-oncology, and psychosocial support, that can run down the tracks and improve the quality of cancer care that patients have access to, and at the same time deal with the social determinants of health that get in the place. So it's a great opportunity. It's a great time right now for NCI comprehensive cancer centers and academic medical centers to get involved in this work, and that is really one of the great gifts of ECHO, is it makes it in a way so easy. Just by being in the building, I'm sure one thing ECHO doesn't necessarily measure for is but the impact they've had on mindset and leadership within specialty centers around the country. That can happen within cancer centers as well. And at the same time, as awareness is raised about inequities in cancer and social injustice around it, ECHO is there with a solution that taps into the very strengths of these centers, as having expert knowledge that needs to be cascaded out to the rest of the community of cancer care providers. At the same time, it's a chance to really respond to patient preference of being treated in their own community. And additionally, it's a chance to have this two-way flow of information. The centers can learn about the populations that are being most heavily affected by cancer because of risk factors and other things. And so they can come to learn, what does it actually take to get high-quality cancer care to patients in rural areas and underserved areas, and have a window into it through their partnerships with ECHO. There's definitely a need. We recently convened an expert advisory council, and we had oncologists from Dana-Farber, Yale Cancer Center, Duke, UCLA. Many of them had experience at other cancer centers. And they, as well as the patients in our panel, the Medicaid directors as well, all said that the biggest gap is really in the difference in care that you have in an academic medical center, NCI Comprehensive Cancer Center, and community-based care, and that work really needs to be done. At the same time, we have the Affordable Care Act. So patients, many of them for the first time, have the opportunity to access care along the continuum, including preventative services. And so the demand will build as well as patients come into care and present with cancer, and sometimes very complex, very advanced cancers, those kinds of cancers that comprehensive cancer centers and academic medical centers are best at treating. So how will the patients be able to get there? And how can task shifting become part of what we really start thinking about? And then the last thing that I would just mention is sort of the context around ECHO. And Don Burwick got at this a little bit today in saying, really look at what does it take to deliver quality cancer care equitably and optimally to the population. What's the infrastructure? What's the patient flow? Where does the know-how need to be? Where do the resources need to be? And how do you make that start happening? But right now we have kind of maybe not a perfect storm, but at least a good storm of forces coming together, of movements, if you will, coming together. So ECHO is a movement itself. Also in this country right now, we have very significant mobilization around social justice and health justice, economic justice, and racial justice. And ECHO can become more engaged and leveraged with those movements and carry its mission forward and its work forward. At the same time, we have electronic medical records and data sets that are helping us really look at not only panels of patients, but in that panel being treated in your center, how many are on Medicaid? What is the race? What is the gender? What is the income level? And do you see that you are leaving patients out? That patients are not coming and accessing the best quality care, and how do you then, now that you have the information, how can we start moving on that as well? And then finally, just workforce development and task shifting, which I mentioned before. We can't continue delivering cancer services as we are now and expect true equity and optimal outcomes for the population. Things have to change. And ECHO can be an important part of that, not only because it cascades knowledge, but creates real collaborative care among providers, as we heard from Uruguay, doing different pieces in the continuum of care. But because of the overlapping, because of the knitting together, fewer patients hopefully will fall through the cracks, and systems will actually be complete, whether they're on Medicaid or uninsured or have full coverage. So I just want to close with the final thought about international work. We're also in our foundation looking at ECHO in developing countries and resource-limited settings. That's been a big part of our mission in other areas, so we're trying to share with ECHO some of the lessons there. And we've provided to them a grant to think both for the U.S. and internationally, how can ECHO cancer actually function? Is it going to be different from other ECHO clinics that have created? What's the nature of those differences? How can it best be deployed in the cancer space? And finally, I just want to thank all the other funders who have stepped up already and sort of paved the way for ECHO, and also brought our interest, reached out to us as well. So thank you so much. And we really have great hopes for what ECHO can achieve, but we always come back to what it was about for Sanjeev and what it is about for so many of you from the beginning, which is health equity and social justice, human rights, the dignity of all people to have an opportunity for health and quality health care. Thank you.
Appreciate it. So being really respectful of your time, there are obviously questions that I could hog the mic and ask these guys all night long, but that's not going to happen. But I want to open up the floor to questions that you might have now, if there are any. Yep, yes.
While we're waiting to see if there's any questions, I meant to start my my remarks with something that maybe you know, but maybe you don't know, and that is that we talk about ECHO and common complex diseases, and cancer kills more people globally than HIV, AIDS, TB, and malaria combined. So just kind of hold that thought. And of course, there's not a lot that's a whole lot more complex than cancer, which of course is not one disease, but many diseases. So I can see the application of ECHO in terms of common complex diseases.
So any questions? One in the back.
So I'm an endocrinologist actually, but I also work at a cancer center. I think the main problem with cancer also is cost of the medications. Is that something you address in your ECHO? How do the patient you diagnose with cancer get access to the medications? Is that something you do?
Patient access to education, is that what you're asking about?
Medications.
The medications, in the context of we know that the medications for the chemotherapy are in some cases ridiculous, which complicates the issue. And so we're wondering how ECHO, I think in rephrasing that question, how ECHO can actually either help with that or not.
Yeah, I'm not sure that ECHO is able to help with that, but the WHO just published a new list of essential cancer medicines, and you'd be surprised at how affordable the generic suite of medications is. Let's say for a full course of treatment for breast cancer, it's $275, which is a lot of money in many places, but not what you might imagine it would be. And then, of course, if you add some of the drugs we use here, like trastuzumab, then it goes up to $40,250. So there are a lot of smart oncologists working on how to make cancer drugs affordable, and there's now a lot of generic drugs. And like I said, you have to be very creative in coming up with solutions to some of the situations in places where cost is prohibitive, even if it's a very small cost.
I think what I would say is that while it may not be directly, I think what Sanjeev and what ECHO is trying to do in this context of as we talked about, equity, social justice, it at least puts the light on it, because we're in places that we're thinking and frameworking these types of questions, and why aren't they happening? So I think in some ways, it may not be direct effect, but I think having the right folk in there actually at least bringing up these kinds of questions that we hope one day will help. I think we got a couple questions. Yep, we have one right there.
I'd just like to add to the story our experience also at ECHO Chicago at the University of Chicago, where we started out in the cancer area by looking at survivorship. We were particularly interested for many of the reasons that all of us know, that there's a big differential in health outcomes for African American women in the city of Chicago compared to Caucasian women, and that a significant portion of that has to do with the survivorship care as opposed to just the the acute treatment of their cancer. And we had an interesting experience around this because unlike so many of our other ECHO projects, we felt like we had identified a need and we wanted to try and manage it. And so we initiated a cancer survivorship ECHO. And we found that there was some interest, but that interest waned relatively quickly. We had never seen that with any of our other ECHO areas. And we thought about what was the reason. And we had called it cancer survivorship. So we looked at the curriculum and we changed it a little bit. And we changed the name of it. We changed it to now what's called a risk-based approach to women's health. It's still basically the same. We added a little piece on reproductive health. But basically, it's a focus on prevention as well as the management kinds of issues that come up related particularly to women then in the cancer arena. And this has been very successful. And so I just wanted to add that experience that now, ours is an urban-based ECHO. And so it's also different in that regard. So the rural story versus the urban story in terms of healthcare need is clearly a different issue. But we have found that there's a lot in a name and that there is much importance of being able to communicate information, but you got to take the right approach.
Well said. And I think in Chicago, you also know, we also suffer in the context of clinical trials. So when you go to an African-American neighborhood and you talk about clinical trials in the wake of what I know people call the Tuskegee, but it wasn't Tuskegee. Remember, it was the United States who Tuskegee was one of the spots, so I'm always mindful of that. So it's not the Tuskegee problem. But when you start talking about clinical trials and not talking about the benefits, it actually does actually have a different sort of resonation of having people sort of saying, well, why would I want to do this? The other thing to your point is that, as you know, coming from Chicago, I've had work in University of Zimbabwe and around Harare in these areas and like that. But I can tell you that Auburn Gresham actually has 0 docs. And the reality is, not only do they have really no access to physicians, that when they do get access to physicians in those community hospitals, they're not adequate. And yet we as universities and we as state universities and all the rest of that stuff, again, we have to look really outwards and sort of say, how are we actually taking care of one another? And I think that that's where ECHO actually at least starts a conversation. So I would have a hard 4 o'clock stop. Is there one more question?
Thank you very much indeed, Max Watson, Northern Ireland. I was really impressed with each one of your stories. I guess my question is, when I listened to you all, I was aware of the need for an ECHO upstream of you and an ECHO downstream of you. And I guess I just find it amazing that there's no HPV vaccine on the Texas border. And how do you get people who are in charge of instituting vaccines into an ECHO to get them to do stuff which would prevent a lot of your and then I think about the success which you guys have generated and then what that will lead into in terms of survivors and their need and so I think it's fantastic what you're doing. I just want you I want the first start and the end to be extended. Thank you.
Yeah, we're all working hard to improve the HPV vaccination rates, not through ECHO, but certainly, particularly in Africa, where there is no real care available for cervical cancer. You really want to start vaccinating young girls and young boys now. But you're still going to have 2 generations at least. Even if you vaccinate 100% of the children now, you'll have 2 generations of men and women who are going to be at risk for HPV-related cancers. But we are working on that too, just not through ECHO.
I I just wanted to end, this discussion with the following, and that's why we have the slide up. And I want, of all people, Dr. Baker, when she says she's really out of space, she was out of space. So I want her to actually, if she wouldn't just take us out on this last slide, and it's of the globe.
What do you want me to do?
Just to sort of, talk about, from the perspective from that we're all one.
Okay, this actually is from Apollo 17, so I didn't see the Earth like this, but but I will say, when you travel around the world in space, you do get that feeling that we are all one people and we are all connected. And why can't we just get along and work together? There aren't. The problems we face are not ones that need new developments and new technologies. We have the smarts, we have the know-how. We just don't seem to have the will to work together.
Thank you, panel. Thank you so much.